Well, I'd love to welcome you all to Spine Talks. This is our series on disc replacements, and specifically, we're going to talk about cervical disc replacements right now. Disc replacements are something that's relatively new in the world, and we're going to bring experts to you. The National Spine Health Foundation has a medical and scientific board, which is comprised of the nation's best physicians. And we're going to speak to some of them tonight about their experience, which is vast, about cervical disc replacements. So my name is Dr. Tom Schuler. I'm a spinal surgeon. I'm CEO of the Virginia Spine Institute and president of the National Spine Health Foundation. And I've been doing cervical disc replacements for almost 20 years. Next, we're going to ask Dr. Todd Landman to talk about his experience and his background.
Welcome, everyone. Yeah, I also have been in practice 30 years of spinal neurosurgery in Los Angeles, in Beverly Hills at Cedars-Sinai, and faculty at UCLA. And I also have been involved in artificial disc replacement from the early 2000s, involved in the clinical trials in the cervicals and lumbars for most of the discs. So we've had quite many years of experience, as well as having some personal implantations into myself. So we can enlighten everyone about that.
All right, next from the great state of Texas, Rick Geyer. Rick, can you tell us about your background?
Sure, thanks, Tom. We've been doing disc replacement, having done my first one in 2000. So it's 21 years since we've been doing lumbar, and then followed with cervical in the early 2000s. So like Todd, we've been involved in, I think, over a dozen FDA trials testing both lumbar and cervical disc.
And Armin from the snowy state of Salt Lake City and Utah.
Well, thank you, Tom, again for inviting me today. And unfortunately, today is about 100 degrees outside, so I wish it was a little bit colder and a little bit nicer. But I've now been in practice for almost 20 years. I'm the founder and director of the Disc Replacement Center here in Salt Lake City, Utah. I'm very passionate about this technology. I've been focusing on it for almost 15 years now. I've been involved in 5 different clinical trials, all of them in the cervical spine. It's a technology that I think is a game changer for our patients. I've had just a tremendous number of patients who come back, are incredibly happy with this particular procedure. And I'd love to kind of answer any questions that any of our patients would have regarding this technology.
What is a disc? I mean, we're talking about disc replacements. What is a disc? What is a normal disc? And what does it do?
A normal disc has 2 parts. It has the nucleus, which is the center, and then it has the rim, which is called the annulus. And when you get a rupture or a herniation, and they're really describing the same pathology. So a rupture is when the ring tears, a herniation is when the soft jelly or the nucleus comes out and then pinches a nerve that will give you the shoulder pain, the arm pain, numbness, and tingling. So typically, most people don't have a problem, but after the age of 40, about 40 to 50% of patients will show some varying degrees of degeneration of the disc. And fortunately, only a small percent end up getting herniated discs that then get what we call the arm pain, or what we commonly term as radiculopathy.
So Todd, what is an artificial disc? We talk about a normal disc, this elastic fiber structure that holds bones together, allows them to move. What's an artificial disc, and why do we have them?
Well, these artificial discs were designed really to replace the degenerative and herniated discs that are in the neck. Traditionally, we would remove the disc to decompress the nerves and relieve the patient's pain, and then fuse it by putting a bone graft or a material with the plate and screws to lock it, which really provided a little less motion of the spine, and the outcomes were very good. However, as the total knee and total hip community found out, in the old days when you had a bad knee and hip, they were fused back in the day. And then nobody would consider having a hip fusion or a knee fusion today. The reason we get away with doing a fusion traditionally in the cervical spine is you have 5 discs. So if you fuse 1 or 2, well, you have 3 other ones that keep moving. Invariably, that increases the stress on the other discs and they fail. So artificial discs are devices that mimic motion of the natural disc. So when we remove the bad disc, we insert an artificial disc, which is typically made up of titanium end plate components and a core of high molecular weight polyethylene. Typically, there are other types of discs that are FDA approved that have different core constraints and mobilities. So these discs allow you to maintain your motion of the spine, but yet relieve the pressure on the pinched nerves and provide stability, provide pain relief, and improve your neurologic condition.
Why have an artificial disc? If we have fusions and they've been done for years, don't they work? Why do an artificial disc?
Common sense would tell you that if you can preserve the motion that was naturally there, that is going to give you a better outcome, right? So again, as Todd mentioned, for a long time, we did not have the proper technology in place. And really the only option that we had available to us was fusion. We now have had a number of different clinical trials comparing disc replacements to fusion. And in almost every single clinical trial, the disc replacements are found to be at least equivalent and in many cases superior to fusion when it comes to what happens to patients in terms of their functional outcomes, what happens to their future surgeries that the patients may need as they recover from the original surgery itself. So with artificial discs, we are able to preserve the natural motion that's normally there. Many times, again, what Dr. Geyer mentioned was that you have a herniated disc that's pinching a nerve that's causing horrible pain down the arm that may cause weakness or numbness. In these patients who come to us needing surgery, now we have the option of giving that pain relief, but then also preserving the function that's there, and that function being motion. And again, this is something that now we've been doing for almost 20 years in this country. For the past 15 years or so, we've had FDA-approved discs available in this country that now can provide our patients with much better options.
We just use the term FDA approved. What does FDA approved mean, and how is that relevant here?
Well, in the US, for example, we've had 9 artificial discs that have gone through FDA trial, and 3 of them were for a 2-level disc replacement. So when they say it's approved by the FDA, it has undergone a very, very rigorous scientific evaluation. Usually it's a randomized. In the beginning, it was randomized artificial disc to fusion. And then as we gain more and more experience, they became randomized to now disc to another artificial disc. So it gives the patients, at least in the United States, the assurance that what we've tested has been rigorously studied. We have patients that have gone to Europe, but their FDA or their FDA-like organization that approves their artificial disc and other instrumentation is not nearly as rigorous as we are here in the US. And while it is easier to get approval for new designs in Europe, I'm actually very proud of the fact that when we offer our patient an artificial disc here, we can safely say that it has passed rigorous evaluations. And most of these studies now have to be followed out for 7 and even 10 years.
One of the interesting things about the FDA approval is that it approves a company's ability to market a product, distribute a product, but the FDA does not regulate what physicians and surgeons can do. So we as surgeons are not controlled by the FDA. So we often do things that are called off-label, which means the FDA trial was for a very specific indication for a 1-level disc replacement, a 2-level disc replacement, but we may choose and take a look and say we need to do a 3-level disc replacement, or we need to do what's called a hybrid, where we do a fusion and a disc replacement. And so that's not governed by the FDA, but it doesn't mean it's not a good approach or scientific.
That's a really good point, Tom. The thing is, the FDA doesn't govern the practice of medicine. And I think as long as you have a discussion with the patient stating that I think that this operation, as you said, a hybrid, which would be a fusion at 1 level and maybe 1 or 2 artificial discs at another level, is the best thing for you because of such and such. As long as the patient is informed and they understand that this is not according to the FDA approval, it doesn't mean to say that it still is not a good operation for a patient. And in fact, I'd venture to say that the 4 of us do a lot of off-label surgeries, but again, we discuss with the patient so that they're aware of the fact and understanding the difference between an FDA-approved product and the practice of medicine, which is totally different and outside the FDA's purview.
Absolutely. Todd, when we talk about that, an off-label, such as a hybrid, where you're combining a fusion and an artificial disc, if artificial discs are so great, why would you ever not do artificial discs on everybody? Why would you bother doing a fusion?
Well, sometimes the patient may have severe arthritis of a disc level and the joints at that level that really make doing an artificial disc, because you have to remember, when we replace the disc with an artificial disc, we're relying on the two joints in the back of the spine to function normally. And sometimes those joints may be severely damaged, and so damaged so much that they're not going to provide the stability necessary to help the artificial discs function normally. So sometimes we might say, hey, we need to fuse that one disc, but the one next to it now also is the one we want to treat, and we can do an artificial disc there. In fact, there was one disc FDA approved next to fusion, and that was the PCM disc, which has now been obsoleted and off the market. So there is a protocol standard in the FDA approval process for hybrid surgeries. There's an ongoing surgical artificial disc trial now that also allows the artificial, one-level artificial, to be placed next to an old fusion. That's called the Synergy disc trial. And so there are trials available, but as Dr. Geyer said, the FDA does not regulate if we choose to use a device in an off-label manner. It's our duty to consent our patients and say, hey, now we're using this in an off-label manner, because really what the FDA is doing is they're saying, hey, this device is safe and effective. And if the physician chooses to use it in an off-label manner, the FDA doesn't care. That's the doctor and patient relationship decision to make. So we can do that. I think the hangup comes with insurance companies, because they like to use the FDA approval rating as the method of approving the surgeries, and then they call everything else experimental, when really it's not, because there have been numerous publications on hybrid surgeries, and in fact, they're very safe and effective. I, in fact, am a hybrid. I have a fusion at C6-7, and I have an artificial disc at C5-6, and my neck works beautifully, and I'm very happy. And I think you're a hybrid, Dr.
That's true. I have two artificial discs in my neck and two fusions. So, I mean, I think this concept of hybrid is important for the public to understand, that it's a great opportunity to treat the problems. When we talk about a disc, we have to understand, as Dr. Landman said, when you have a disc, you also have two little joints in the back called facet joints. So I always think of every level of the spine as a three-legged stool. And you need all three legs intact for it to work properly. And what we do with the disc replacements is put in a new disc in the front, a metal one with plastic, or there's also one with ceramic core that we can use. But we put in this new disc, but we still rely on those two joints in the back. So those two joints in the back have to function properly, or somebody won't get a good result. And so that's important to understand. So Dr. Kachaturian, when people are getting, and you're talking to them, how do you decide whether they're going to get a fusion or an artificial disc or a combination?
Before I can answer your question regarding what kind of options we offer, what makes me decide in terms of whether we should do disc replacement or fusion, I just wanted to add one more point regarding hybrids. So hybrids can be performed in a primary setting where a patient has a multi-level problem in their neck, and one level may be amenable to a fusion, and another one may be amenable to disc replacement. And Dr. Landman described that scenario very nicely. But it is also common for me to see patients in my clinic, and I'm sure we all see in our clinics, where patients have had prior fusions performed. They come back to us with a problem next to that fusion, needing more surgery. And this, I think, is another beautiful application of motion preservation technique that artificial disc replacement offers us to perform this type of secondary hybrid surgery, disc replacement next to a prior fusion. Now, again, just as Todd Landman mentioned, it becomes somewhat challenging at times to get something like this approved with insurance companies, but it's one where I have done many peer reviews with insurance companies and tried to get them approved, because I believe it's going to provide them better function in the long term to have an artificial disc replacement next to a fusion. Now, going back to answering your question that you addressed.
Before you do, can you explain to the public why it would be good for them to have an artificial disc next to a fusion?
As we talked about, there are 5 discs in your neck. So if you've had 1 or 2 level already fused, you've already lost significant portion of your motion in the cervical spine. So then now you've developed a problem next to that. So we all believe that there's this domino effect that happens with fusion. You lose motion at one or two segments, you put a lot of stress at the next level, and then if you keep fusing it, I've seen certainly in the past some patients who've had their entire neck fused, and at that point in time, the only way they can turn is by turning their lower back or their thoracic or middle back to be able to look from side to side. So preserving the functional aspect of our cervical spine, which is motion, is critical. So if we can address this additional level that now has become diseased with artificial disc, we are effectively giving that patient a new lease on life to be able to continue to function and be able to, look around their environment and do the daily activities of their life without the stiffness that comes along with fusion.
The problem with fusions are that you put increased stress in the levels above, and the FDA studies have shown that there's a much higher rate of needing surgery at an adjacent level with the fusion compared to artificial disc. It's about 1/3 to 1/4 the chance. And that's why what Armin said is a great solution for those patients that had a previous fusion, and now they come back and they wear out the next level. And one thing we didn't say earlier, just like if you had an arthritic hip today and you went in to see a surgeon and he said, well, I think you need a fusion, well, you would turn around and walk outside, because there's no way. Everybody gets an artificial hip or artificial knee. We're getting very close to that way in the cervical spine.
One of the great studies that came out in the past couple of years was showing that how effective and beneficial spinal surgery is on improving the quality of lives. And we've all known that hip replacements and knee replacements really improve the quality of people's lives. Well, this study actually showed that spine surgery, modern spine surgery, and I think a lot of it's because of disc replacements, but all the minimally invasive techniques we do, that spine surgery is even more successful than hip and knee surgery in improving the quality of lives. And I think it's these concepts of motion preservation, decreasing stress on the adjacent levels, and then being able to focus exactly with very extreme surgical precision on the problem and solving it with a device that works much like the normal anatomy, that we can take out a degenerated, broken part and put in a brand new part and have it work as good as the other one and get people back to their lives. And so that to me is so important, and why we're celebrating and discussing cervical disc replacements tonight.
And it used to be said that fusion was the gold standard, but that is very quickly being challenged by artificial disc. And I would say, of course, the four of us here would believe that disc replacement is a gold standard, but, unless you have certain severe cervical conditions, the artificial disc is really our go-to operation. And I think all of us believe that we find reasons not to do the artificial disc. In other words, if a patient has a problem, we say, okay, well, you passed all the tests, so you're a great candidate for artificial disc, not that, oh, you're a fusion patient, maybe you're a candidate for disc.
Correct.
Yeah, but I think it's important to understand that fusions aren't bad.
No, they're
Disc
not bad at
replacements
all.
are just better.
Yeah, and just that, as you alluded to, Tom, that the body likes motion. That's the way the good Lord made us, is to have motion, not to fuse our body parts, and just like hips and knees.
And again, I think, Tom, you asked me the question, how do I make the decision whether someone should get a fusion or a disc replacement? There are a few, I think, fairly, at least in my practice, uncommon, because when I look at the proportion of the disc replacements that I do versus fusion, currently my practice over 95% disc replacement in the cervical spine and less than 5% fusion. But the few patients who actually end up having a fusion do have some sort of a pathology that the artificial disc will not address. One that would be if that patient has what we call clinical instability. So that they are so mobile, they have so much motion at that segment that if you were to put an artificial disc in there, that continued kind of pathologic motion or abnormal motion would continue and would be to the detriment of the patient's overall function. So a patient like that, whether that's as a result of some sort of excessive degeneration and wear and tear, or as a result of some sort of trauma, is still better treated with fusion. A patient who may have excessive arthritis along those two legs on the back of the spine that you talked about. So if they have really severe facet arthritis, that makes their neck pain to the point where by replacing the disc, we will still not address the majority of their neck pain. That may be a patient that may be better served with fusion. A patient that may have really abnormal kind of surface to the disc end plates, or kind of the underlying surface of the bone, that precludes that patient from an artificial disc, that may be someone that we may still end up doing the fusion. So I think fusion will still continue to have a role in our practice. But fortunately for some of us, especially in this forum today, who have used the artificial disc technology and have expanded our abilities and our technique, are now will use artificial disc as our primary treatment option and fusion only as kind of as our backup.
So I have some online questions that have come in. Here's one from Tampa, Florida. And the question is, do I have to go to Europe to get a disc replacement, or why would I get it done in the United States versus Europe?
When I first opened up the disc replacement center in 2014, that was a very, very common scenario here in Salt Lake City, Utah, as well as in the surrounding areas, that commonly I would hear patients that were traveling to Europe to get artificial discs. So part of my focus, both locally in Utah as well as kind of along the West, was to really focus on educating my patient population, informing them that this option is available to us here. It's been available in the United States. The first artificial disc was approved in 2007. So now it's almost 14 years. So we have the technology here. We have the expertise here. And at the current time, really, I see really no reason why a patient should be traveling to Europe to get any type of cervical disc replacement. Both the options as well as the experience as well as the techniques is available here in the United States.
Todd, do you want to add to that?
Yeah, and most insurance companies happily approve cervical artificial disc replacement here in the United States. 1 and 2 level is very easy for, I'd say, most of the insurance companies to authorize. So your health insurance should provide authorization. The other thing I wanted to mention about these artificial discs in the cervical spine, because we were relating it a little bit to like a hip replacement, which might last 25 years. These artificial discs, some of them have lasted and been on the machines for 70 life years. So they're really a one-time thing. They really don't wear out, at least the hardcore polymers that are most of the discs that are FDA approved except one. And possibly the ceramic will last as long as well. But so they're really, it's a one-time thing if they're placed properly by a skilled surgeon in the right area to treat the right condition. And most of these never need to be revised. So it's a very satisfying operation, Tom.
So Rick, let's talk about multiple levels, because the FDA had 1 and 2 level studies. The insurance companies fairly regularly authorize 1 and 2 level study or 1 and 2 level treatments. What about the people that have 3 or more levels? Can you talk about that?
It happens. People, they're not cookie cutters. They don't, come out of the factory, so to speak, and just have 1 and 2 level disease as they get older. So 3 level is not uncommon. 4 level is certainly lesser. And we do that many disc replacements. It's not common. I mean, we don't do a lot, but there are some individuals that are truly candidates for that. And the option for them used to be, well, you do a 3 or 4 level fusion. And as Todd said, we only have 5 disc in our neck. So if you do a 4 level fusion, guess what? That last disc that may or may not be normal is toast and will need another operation. So it's not common. And, your insurance is probably not going to pay for a 4 level unless you have some extraordinary situation with your insurance or self-insured. But it's a reasonable option. It's, obviously not as common as 2 level. And in my practice, I probably do as many 2 levels as 1 levels, not that many 3s, and, 4s are rare.
The insurance companies over the past 5 to 10 years have been much more diligent in gathering outcomes data. And some of the data that's been published does show that artificial disc patients cost less money to the insurer and their outcomes are better. So I've used some of that data to then, if I have a patient comes to me who needs a 3 level disc replacement, or if a patient needs a disc replacement next to prior fusion, to then even though it's not part of the insurance company's policy guidelines to cover these hybrid surgeries or to cover 3 or 4 level surgeries, I will insist on having a peer-to-peer review with the insurance company's representative, who usually on the other end, if we can ask for it and get it as a spine surgeon, you can make an argument to have them pay for this off-label or 3 level surgeries. And not uncommonly, I've been able to get them approved. And in the case where we can't get it approved, some of these patients have looked at Europe to possibly go to Europe to get a 3 or 4 level surgery performed. There used to be a time where perhaps traveling to Europe cost a little bit less money, but I believe now, especially with the cervical spine surgery, many of these surgeries are being done on an outpatient setting. The costs of having these procedures done in the United States are equivalent, if not less, than they are to travel to Europe.
Do you have any experience in converting an artificial disc to a fusion, or a fusion to an artificial disc, maybe a one that didn't heal, pseudarthrosis?
I've had 2 patients in my recent, one was about 2 years ago and one was about a year ago, who've had prior fusion performed and they did not heal. And I felt it was almost nature fighting what was done unjustly by fusing a segment that wanted to move. And in those patients, I had a conversation with them and took them back to the operating room. And really the strategy was, we will go in there, we will take out what has not fused. And if the environment within that disc was still amenable, and without going into technical details of what that means, but if the environment was still amenable for an artificial disc, that I would convert them to artificial disc, and I was able to successfully convert them to artificial disc. And those patients went on to heal and have done incredibly well, have sent me many cards, many patients of friends and family members and other colleagues. So yes, that can be done. On the flip side, if you have occasionally a patient who has received an artificial disc and for whatever reason, either it was done improperly or the sizing was not correct and they've had a failure, then those patients may need additional surgery at that level. Some of those I have converted them to another artificial disc and achieved more proper positioning, more proper sizing, and have done well as well. And I've had 2 patients who've had artificial discs that then once they were taken out, the amount of damage that had occurred to the underlying bone was such that it could not support an artificial disc. Those patients were then converted to fusion.
I've been reversing fusions, failed fusions, and in some people that, like we were talking about, who have 3 and 4 levels already fused and they're so restricted. And I had one woman that the first one came to see me. She had a 3-level fusion and her C6-7 was normal, but it had failed because of the stress load on it. And she wanted an artificial disc at cervical 6-7 and asked me, hey, is it possible to change one of my fusions to an artificial disc? And when I did the CAT scan, which is critical to assess the facet joints to make sure they still look open and healthy, well, they were at the one above at C5-6. So I was able to cut out that fusion, which was solid, and place an artificial disc there as well as at C6-7. So then she went from a 3-level fusion down to a 2, and actually she can play golf again because she can get her head down. So she's very happy, and that was 8 years ago. So you can convert selected patients, but yeah, but like Armin has done, and I know Rick has done, if you have a pseudarthrosis or a failed fusion, most of those convert quite well to artificial discs. I have a very large series, and they do, like Armin said, they just very happy patients, and they keep their mobility, they regain some mobility, they have their pain scores are superb. They're very grateful patients.
So we have a question here from up in New York City. So Rick, if you can comment, the question is, how do I find a surgeon that can do an artificial disc? And do all spine surgeons do artificial discs?
Well, not all surgeons do the artificial disc, and you're going to have to do a little bit of research. But like any other surgical procedure, you want to go to a spine surgeon who has experience, not just a little experience, a lot of experience, because I think we all know the more you do, the better you get. And it's that way for any type of surgical procedure. So it's going to take a little bit of research. And, I know there's lots of social media areas, but you can also be very frank and honest. If you go to see a spine surgeon, say, hey, do you do a lot of these artificial discs? And if he says, well, I do maybe 1 a month, that's really not good enough. And then ask him honestly, say, listen, if I was your mother, or I was your sister or brother, who would you go to? Who are the big, artificial disc gurus? And that's what you need to do. I mean, I personally have had a couple surgeries, and I've always gone out of town to the people that had the most experience.
It never hurts to get additional opinions. And I think what COVID has done over the past year, it provided us a platform to do telemedicine quite commonly. And at least I would say once or twice a week, I'm doing telemedicine consultation with patients out of my area who have seen another surgeon and have been offered fusion, and then provide them my honest opinion, whether they're good candidates for artificial disc replacement. If they are, they may ask to either come out and have surgery here in Utah. An alternative would be if I could recommend someone in their area who's perhaps known to me as a colleague who does artificial disc, and that would be another option that I can offer to them. But that's an option that's available to, I think, most of our patients. If they're been told that they need fusion, I always advise them to get at least another 1 or 2 opinions and see if they would be good candidates for artificial discs.
And Tom, the other thing is patients are becoming better and better educated because, as Armin said, we see, and I see a lot of patients for second opinion that have been told they needed a fusion. And they said, I was reading about the artificial disc and it doesn't make sense. And they go back to the hip joints and the knee joints. So we see a lot of second opinions, patients seeking the artificial disc too.
Right. I have patients out here in California. They will come in. They are so educated here because they want to live this active lifestyle and they want to keep mobility. And they'll come in and tell me, Tom, they'll say, I want this particular disc of the 6 discs that are currently on the market and available. They'll say, I prefer to have this specific implant. And, that's how educated people are getting. So they are doing their research, and the internet has been helpful. And as Armin mentioned, with the telemedicine, we're doing a lot of out-of-state consults and people that are, many times where people are told they have to have a fusion, they're not a candidate. And I look at their films and I guarantee everybody on this panel, and you're a perfect artificial disc candidate. I don't know what they're talking about. So it's always good to seek out experts who have done lots of these. I recommend skilled surgeons who do many, at least 50 plus, I recommend patients to go to. They can't just go to a guy who dabbles in disc replacement.
Even though artificial disc surgery may sound similar in its technique or its approach to cervical fusion, I think artificial disc surgery is so dependent upon really doing the proper technique and the proper sizing and the proper positioning of the implant so that it functions in a proper way. That is one of the keys to a successful outcome with artificial discs. And in fact, as I've been asked on a number of occasions to review some of the failures of the discs, or I've seen patients in my practice who've had artificial discs done elsewhere, most of the failure doesn't happen because the implant failed. Most of the failures that I see have happened because of inappropriate application of the implant, either in a patient who didn't have the right indications for that particular surgery, or even if they had the right indications, it's just that the surgery itself, from a technical perspective, was not done correctly. They were improperly sized or improperly positioned, and those discs may fail. So I think the experience aspect of doing artificial discs, just like it is true for hip replacements and knee replacement. We keep going back to that. If I needed a hip or knee replacement, I certainly would find a surgeon who has tremendous amount of experience and has good outcomes with that particular procedure, and go have that surgeon do my hip or knee replacement. Same thing applies in the spinal artificial discs.
A fusion is very forgiving, whereas the artificial disc is not forgiving. And that's why you just can't pick it up and say, oh yeah, I can do it. I can do a fusion, because it is much more technically demanding than a fusion. And a lot of factors go into the decision-making, what prosthesis you're going to use, what kind of stability does the patient have, what's their anatomy look like, what's going to be the best fit, and again, position it properly. So with the fusion, it's basically clean the disc out real fast and put whatever fusion device you need and put a plate on. So not that that's simple, and I don't mean to minimize it, for people that do fusion, but doing an artificial disc, particularly in the cervical spine, is much more demanding.
Cervical fusions are a standard operation. They're technically demanding, but they're very forgiving. It's you don't have to be as perfect and precise. Disc replacement surgery needs extreme dedication, skill, and perfection to get the implant in the right place, use the proper implant, and get it to succeed. So it's important for the public to understand that A disc replacement is a harder operation to perform, more technically demanding, but it has a significant reward to the patient at the end when done properly. There's all these different implants have gone through. We've had multiple generations of implants. Is there a difference in the implants, and how do you choose an implant for a patient? I'd like each of the panelists to answer that.
Well, each implant functions a bit differently. I don't want to go through all 6 of the implants at the moment, but I mean, the anatomy depends. So typically in the lower cervical spinal, if the patient has a high angle slope on the standing x-rays, I'm getting a little technical here, but I want a disc that's going to resist shearing or sliding because there's that tendency. So I use more of a fixed core artificial disc that will allow and help resist shear to protect the joints and the nerves a bit better. And then as I go higher, I'll often pick a slightly more mobile core to provide the more functional mobility that the patient needs, and sometimes the compressible core as I get higher up as well. So each level kind of depends a lot on the anatomy, and selecting the proper device, I believe, optimizes outcomes, and placing them properly, as you mentioned, Tom, is so critical. It's much more difficult to place these things in the right positions, but knowing this, what we call the center of rotation, where the disc needs to be to allow the vertebrae to roll normally, is critical. And like with hip replacements, there are doctors that do hip replacements, but then there are doctors that do the revision hip replacements, and they're different guys. And so I think we would classify ourselves as revision guys and initial implantation guys both, because we have that experience. So that field gets smaller if you've had a disc that's failing, on who's really going to be the expert for the patient to select at that time.
Tom, in my practice, I currently use 4 different discs. I've become very proficient at all of them. And I use Mobi C, I use ProDisc C, I use Simplify, and most recently I've been using M6. And I think along the way, as I heard my colleagues, I've heard Todd talk about some of the discs that he has used. I've talked to Rick, some of the discs that he has used, and also colleagues across the world. And, what I can say that we don't have the perfect disc yet. We don't have a disc that is the absolute champion, the Olympic champion of discs. But I do think that we have some very, very good discs that used with proper indications in certain patients, given whatever the given pathology is, as well as a number of different other parameters regarding the alignment, etc. So what I try to do is, as a result of my experience, as well as a result of observing some of my colleagues use a variety of different discs in different environments, I feel like I've become fairly good in being able to choose the right disc for the right patient. And I think Todd alluded that a lot of patients will come to us having either been marketed to or having done some research and wanting a certain disc. And if that happens to be a good disc that is, fits them, fits their needs well, I have no problem providing that surgery to them. But if I believe that another disc is going to give them a better outcome, I will certainly explain to them and educate them as to why I believe that this other disc may be a better option for them, and then go on to have that surgery performed with a disc that I believe will give them that best outcome.
And we do use a variety of discs, and we try to custom fit each one to the patient. But on the other hand, just to bring us back down to earth, I have to quote one of our colleagues. It says, it doesn't make any difference. Just learn one, do it well, perform the operation the best you can. And if you think about it, that's better than someone mastering or being a master of none. In other words, just choosing willy-nilly any different disc or the new disc that comes out. And I think his point was that whatever disc you use, just make sure, as Armin said, you know the ins and outs, you have perfected the technique, and you understand why you're using one over another one. And when you do use it, you're doing it the best that you can do.
The technology has evolved, and the current generations are much better than where we started. And I think that they do a great job. But we all know that there'll be more technology that'll come along. At some point, we will have implantable artificial discs that are human derived, 3D printed. And so, we're eager to get those days.
They're already working on
that. Right. And so, someday that'll be there. That's not realistic. So if you have a spine problem today, I don't think you need to wait for a theoretical advance that's coming that may not be available for 20 years, 30 years. You got to continue to live your life, and your health depends on that. If you can't move, you can't take care of yourself, you can't stay healthy. And if your heart gives out because you didn't exercise because you're hurt, then you've lost everything as well as the quality of life.
I mean, we have 10-year follow-up on 3 artificial discs. And as you said, there's no reason to wait, because these artificial discs, as they were designed, and the ones that are 10 years old are not, our current generation. So they're just getting better and better.
That's exciting. So I'd like to give our 3 experts here a chance to say whatever they want to say about spinal's healthcare or cervical disc replacements or whatever. So we'll give you each 3 chance to give some parting words to the public.
I believe that in the next 5 to 10 years, when we call the insurance companies, and if we're asking them for a fusion, they're going to be saying, why aren't you doing the artificial disc? I believe the whole parameter is going to turn. Where now, when we say we want to do an artificial disc, they say, why don't you want to do the fusion? Even though we get paid more to do the fusion, we get paid less, believe it or not, to do an artificial disc, which is much more challenging and skillful to place. But I believe that's going to change, because the outcomes, as Dr. Geyer and Armin said, and Tom, the studies, the 10-year studies just show the superior outcomes of neck pain, arm pain, neurologic success, overall success are far superior to fusion, and the adjacent level surgeries are 2.5 times less with artificial disc compared to fusion.
So, Tom, my parting words for our patients out there who may be listening to us today is that as I've gotten older myself, because when I look at myself as a younger surgeon, it seems like I had perfect health myself, and things didn't seem as real. But now in my 50s, it would not be uncommon for me to get up in the morning and have stiffness in my back or in my neck. And I realize how important motion it is to my well-being, and how important it is for me to do all the things that I love to do, whether it's being at work and taking care of my patients, or going out there and mountain biking or golfing or skiing. So it becomes more and more real as a physician and a surgeon who is maturing to understand how important motion and function it is to our well-being. And when we talk about artificial discs, really this is an option that allows us to take care of the patient's symptoms and do so with much better functional outcomes. Again, for the long time, cervical fusion was probably the gold standard and the king of spinal surgery. But I believe now that that particular crown has been displaced, and artificial disc is the current king of the spinal surgery.
It really is great technology. And I think that, if you do have a neck or arm problem and you've been suffering with, and you're thinking, well, I don't want to have surgery, you at least owe it to yourself to visit a spine specialist to see what your options are. And I'm not saying you should have surgery, but if it's something that it can improve your quality of life and let you get back to doing the things that you love to do, it is a wonderful, wonderful operation. And I always tell patients, it's really your quality of life that determines whether or not you should do the surgery. And a lot of patients say, well, I'm in my 50s, it's okay, I'm going to slow down, or I'm in my 60s. It doesn't have to be that way. Not that we can bring back the fountain of youth, but at the same time, we can improve your quality of life. And this is a proven technology that in the right hands is safe, and long-term results are excellent.
This has been excellent. I'd like to thank Dr. Geyer, Dr. Lehman, Dr. Kachatarian. I think that we have opened a lot of knowledge and shared it from 4 experts who have decades of experience in this to help people understand the benefits of this incredible technology. My advice, my closing words are, if you can keep motion, keep it. And I think that this technology is great. Find experts who are proficient at it. And with that, I think that you can regain your life. And with that, I'd like to thank everybody and look forward to the next part of our spine series on Spine Talks. So thank you all.